It's really great. This is our 14th event being held by Net Patient Network. It's been an amazing time. We've been, so much has happened, and it gets better year on year. Last night we had the dinner. I know many people here were there, and it's part of our community building, where we all can share stories with each other, support each other, tell us, we can hear what other people are going through, and they appreciate what we're going through as patients. And we know that with this rare disease, not everybody knows what it's about. So it's really helpful when we get to talk to people and, on the same path. So today we have a big crowd, probably one of our biggest crowds we've had. And we have a good selection of talks to come. And we'll have our Q&A then after lunch, and I know many of you have, really enjoyed the Q&A. It's probably the best part of the day. I'm delighted to be joined by the physicians here who have given their time to come and talk to us and educate us about our disease. I encourage you to think about what questions you may want to ask, and if you don't want to ask them, please ask one of our committee members who are very happy to ask on your behalf. Can I ask the committee members to stand up so at least you can be identified by people? So these are our committee members. If you want, they're all sitting down now. If you want to have a question asked on your behalf, just ask one of them to do it, and they will. Also, I do want to thank the committee for all the work they do during the year. It's amazing, and so much gets done. Everybody, we're all volunteers. Nobody gets paid. We're just doing it because we want to help, and it's worked very well. And I also want to thank the doctors for the cooperation that we get from them. And yesterday we held a nurse educational program here in the hotel, where we invited the Irish Cancer Society nurses to come along. And we had presentations on what neuroendocrine tumor is, how it all works, what the NET system in Ireland is, about PRRT, and it went down really well. And that's the first of more that we'll have planned for the coming years, and we'll widen the audience as well. So we want to raise awareness of the disease amongst those communities that maybe don't know much about us. And I think the Irish Cancer Society, and Laura's in the corner there from the Irish Cancer Society, she was at the course yesterday. So they are the first protocol oftentimes for many people. So for them to have more knowledge of NETs is wonderful. So we did that yesterday. Then we had our dinner last night, and now we're here today for the actual patient day. So I do want to thank our sponsors, Ipsen and Novartis, who've been sponsored us from the very beginning. And then we have a new sponsor this year from Boston Scientific. And I know the reps are here out there in the audience somewhere, but thank you very much for doing that. And my last thing I want to say is about a survey that INCA, I think most people here know what INCA is. So International Neuroendocrine Cancer Alliance. It's a global body of which we, Net Patient Network, are one member. So INCA is currently doing a survey called SCAN, Survey of and Challenges of Access to Diagnostics and Treatments for Neuroendocrine Tumor Patients. Big long mouthful. But the SCAN itself survey is a follow-up to 2019, and many people here in this room would have responded to that in 2019. 2,500 patients around the world replied, 436 HCPs. And in that, because we had over 100 patients from Ireland, we got Ireland-specific data analysis. We need to get to over 100 again this time. We're actually, as of Monday, we're at 98. So we need a few more people. So I'm going to ask those in the audience here who haven't done it, can you please scan the QR code and do the survey? Or log on at the website, which is incaalliance.org/scan 2025. So please, if you get the chance to do it, please do. We need to get over that 100 figure, and then we get Ireland-specific data, and we'll be able to compare back to 2019. The clinicians, I'd also ask if you can do it, because there's a HCP version of this. And as of Monday, we had 2 HCPs that done it. So we need more. With that, I'm going to ask Dermot O'Toole, National Lead for Neuroendocrine Tumours in Ireland, to come and talk to us and give an opening address.
Thanks, Mark. Thank you, Mark. Good morning, everybody, and well done in braving this the elements. Got an amazing crowd, and it's lovely to be here in this warm interior as opposed to outside. Mark, that last comment about the two HCPs. Now we were only aware of it yesterday morning at 11 o'clock, so I can't let you off with that. Just to congratulate the committee members and Mark for the great work over the year. A lot goes on behind the scenes, and 14 years is a long time. Yourself and Tommy getting this up and running with various people on different committees, and some of them are not with us any longer. And the first thing I always think about when I'm driving out and getting out of my car, there are some members that were here last year that are not with us this year. Just a thought for them, and I suppose that's what it's all about, us trying to improve things and improve communication. So just to think about that bit without being negative, but that's what we're about really. The committee here has done a great job because communication is the vital thing, and congratulations also on this nurse initiative that you started yesterday. That's great. Having the Irish Cancer Society on board is something that we've strived for a number of times, and in fact now it's working better and better. And I think that going forward with the committee, I think it would be nice that with us in the carers in the hospitals, that we would link in with the Irish Cancer Society and try to have a better. So for people who are alighting for the first time the Irish Cancer website, I'd love to see a link going to the Net Patient Network and also to the hospitals where people can reach out. So in other words, simple things, little win-wins really, and it just there's a few little areas that we could work on with that in mind, and your feedback in that would be very good. So just a couple of things. First of all, you can put the slide, please. So this was something as an update, and you can see here, hopefully you can see, can you all see there? Because the screens are a little bit low. So in the background there, we have, of course, our dearest friend, Tommy Gorman. And we decided that how can we mark his importance to us as a group, collectively. And I'd met Colin Davidson, who was a very famous portrait artist, and some of you will know him. And it transpires that Tommy knew Colin very well. In fact, I imagine Tommy, with his breadth of knowledge and all his connections, through a lot of business, in fact, Colin's way. And I suspect that, and I think Colin sort of gave me the nod on that as well, without going into any detail. But anyhow, decided to commission this called the large-scale portrait of Tommy. And given the fact that Colin knew him personally, Tommy wasn't. If you scroll the internet, you'll find photos of him. You never find one with a smile. And when he's smiling, you're not sure that it's really authentic either. But there was an in between a smile and just sort of a warm connection, and so Colin, also pity is gone. Colin managed anyhow to do. We were so delighted with the portrait, and we decided that we'd hang this collectively in the hospital outside of the Net Patient Clinic. The liver clinic, now it's Net Patient Clinic. We fought to get that done as well. But so when you're waiting there to come in, I think it's nice to have a little tribute to honour Tommy, who was really the godfather of setting up Net in Ireland, and to remind people in an inspirational way of his journey. Over 30 years he lived with it, and we take great solace from it. We were fortunate, of course, to have Akira, Moya and Joe, Tommy's family there. And that I chose that photo. There were many different photos because it was so hard for them to come back to a hospital where he passed, only a little over a year ago. But that's part of it as well, because so many of you here are family, not just patients. And of course, the hit that's there for families with either loss or going through the diagnosis all the way through the journey is a very important thing. They were so gracious, and Kira said a few words, and Joe then mentioned a few words as well. It was and it was so warm to have them there, and they were happy, genuinely happy. But I also, and you can imagine how difficult it is. But I hope that they will also take great solace in the fact that their family member is such a great leader, is there to inspire so many other people, and so we're happy with that. That was something we did in October. Colin is somebody he had a book launch as well. If anybody's interested in his works, he had a book launch just last week in the Royal Irish Hospital Kilmainham, and it's a fascinating book about his insight into what he did. He did a large-scale portraits of people who were, not well known, not known at all, in fact, in the North, the Troubles, across both divides. And it's fascinating to read that chapter in his book. So if you're interested in that, and it's not terribly expensive, the book either. But anyhow, it's not a plug for him, but it's just really interesting. A great character, and he said some beautiful words as well. Just a couple of other little updates, because, we have a big team now, or a bigger team, and, Hussein, of course, who's a first net physician in Europe, full net physician in Europe, and he's been doing great work, and Mark and Donal, and we'll have some updates on that, and they'll fill you in on other things, but I'm just giving you a little overview. We lost Lisa Cullen in our group, who's been there for a long time as well. And Lisa's gone back to do some studying, and she might come back to us in another guise, because she's doing work in survivorship in cancer. And we wish her the very best of luck in that. Lisa was my right and left arm for a long, long time, and many of us. But she did amazing work, and I just want to formally pay tribute to Lisa, because she was outstanding, and I'm sure she'll get involved again. I know that you had plans to get her involved in the nurses and all that, and it was up to her, of course, but I didn't get involved at all. But I suppose she might maybe make a clean break from it and then come back to it. And I suspect we'll see Lisa again, and we'll certainly hope to. She'd be very welcome in our group in any form. But Lisa moved on and gave us so much, and we were placed by an extremely delightful Orla Dunleavy. Where are you, Orla? Can you stand up, please? Yeah. And yeah, we're very lucky to get Orla, who's been working in our group before, and we're trying to protect her a little bit so that she doesn't get the full brunt of everything so far. I mean, there's an educational part to it, there's a settling in, etc., and that's great. And then on top of that, it's nothing to do with the National Cancer Programme or that, but the hospital actually had an initiative of creating advanced nurse practitioner posts, okay, which is different. It's more involvement. Nurses can be involved in prescribing, and maybe prescribing some somatostatin analogs and other things as well. It's a journey that we've just started. And we were very fortunate to also have a person who's involved in cancer care already, Anya Sheridan, who's there. I saw Anya very briefly, and she'll be, Anya, can you stand up, please? So, Anya Sheridan, just to welcome you. We'll be starting fairly soon when her job will be filled then as well. So that's very exciting for us, because we hope then that we will have a more sort of vibrant critical mass, so that we can, follow up on patients who've started on somatostatin analogs, and have maybe another form of clinic that will be sort of more directed and help out with communication. And it's something that Mark and I and Tommy, and over the years we've strived to achieve, because we've been very skeletal for so long, and now at least our critical mass is increasing, and that's just to fill you up with that, and that's, I think, a very positive step. We will also, with Mark Doherty, who's been very successful Mark's been very successful in our group, but that's only probably less than half of what he does is net. He's also the lead in the sarcoma group, and that's very busy as well. But we have a new oncologist who will be a bit like Mark's ultra image, let's say, in sarcoma net. So we'll have a new net oncologist as well. So that's also important for, not only covering, but just as volume increases as well. So there has been an increase in terms of staffing levels. On the negative side, of course, I would say that the four-letter word gallium is still a problem. A little bit more going on in James's hospital. We still only have 2 hospitals doing it. It still is a fiddly scan to go, and for any of you who are new and waiting for gallium scans, apologies. And we've tried everything with that, and we've really worked hard with the National Cancer Control Programme. Richard O'Leary was there for the last number of years, and we tried hard on that, and it's still problematic. And it's problematic not only that, but in many places in the UK as well. Some of the big centres in London can get around it a bit more, but we're finding it difficult, I must say, still, in terms of delays to getting scans done. Some patients were doing tetraetide scans before surgery, so we don't delay their surgery. But anyhow, that's one area still we really have to improve on. I think that access to specialists has improved. We see overall, we think that our pathways, that patients seem to be coming to us quicker once they've had a diagnosis. Now, you may, at our questions and answers, sometimes we're surprised still to find people having a bit of a, a difficult journey to get to a net specialist either in Galway or in Cork or in Dublin. And maybe we'll come back to that later. The treatments, Hussein will talk about that, but PRT, it's been going now in Vincent's, and that's mostly positive. I'll come in the negative and I said, well, just give you the positive. That's going well. We've got 2 treating physicians. They're not here, but we must get them the next time, Mathilde and Nicola. I think you've had, Nicola spoke last year in Galway. I wasn't there. Was it Nicola? Was she not there? Oh, I thought she was there. Anyhow, that's going well. And there's a separate team that's looking after patients with that. And some of you might have had experiences with that. It's great that we can do it in Dublin. I mean, in Ireland. And one of the downsides, of course, is that because the drug is licensed and approved, the reimbursement comes with that approval. But there are a number of patients who have got your type of disease that don't fall under that licensing agreement. And so the clinical indications, if it goes outside of those licensed arrangements, it may not be covered. And we'll also hear from the treatment abroad. Before we were sending people abroad for treatment, and now some patients have been refused to be treated, to get a treatment abroad on the strength that if it's not approved in that indication. So we'll talk about that a little bit later, but basically, when something's approved to be reimbursed by the state, it's approved because it's shown it's to be effective, right? And that's fine. And that comes from the clinical trials and going through the FDA in America or the European Medicine Agency in Europe to get approval. And that's very important, of course, that we stand over that. But because NET is so particular and fidgety and complicated, we feel that, and not only we, like the world experts around the globe, there are a number of people who don't fit into, let's say, the clinical trials category where the treatment would be and has been shown to be a benefit. So don't fit into strict criteria. And we're hopeful that we will get some sort of derogation that the national group, whether in partnership with the people from Cork and Galway, so if we decide that a patient, even though they don't meet the strict criteria, that if we say that it's reasonable to do it, that they'll go with it. But we don't know where we are with that. There's a big sort of move within the HSE to look at. We've submitted a very complex proposal to hopefully to get that over the line. But we can't make any promises. And Mark and for Doherty, I mean, we won't go into that, but it's the same for many other treatments of other cancers. So new treatments will come on board, like chemotherapies and all the rest of it, or immunotherapies. And there might be quite a delay before it becomes approved in our country. And unfortunately, it's created a little bit of a conundrum for us, because before we were able to send people to Uppsala or to Rotterdam or to the UK, and those who are now excluded, they were formerly included, but because they don't come under the remit of the approved license. Does that make sense? I mean, it's important that you understand, because now it only affects a small number, but for me, everybody's as important as anybody else. So I mean, look, we'll try to get around that. We're working hard on it, actually. That's it. I mean, just to say once again, Mark, I mean, amazing, like 14 years, brilliant work. You've been outstanding. But I think we're so lucky to have Mark, because Mark is, not only because he's led and helped co-lead with the committee so well here, but your experience in terms of what you've done as president of the INCA group. Like INCA, for people who don't know, like that's an amazing cogwheel of different brainy people around the world working together with different societies. And like their website is exceptional. Like if you go to their website and you're looking for information, it's all filtered, so it's all been approved in so many rubber stamped, etc. So it's not just somebody willy-nilly posting things on the website. It's really, really excellent. And Mark, like your work behind the scenes of that has been amazing. So well done.
Thank you, Dermot. I'll ignore the last bit. uh, I think it's great to get that overview from the inside of what's going on in the net clinic, and I think we as patients we don't see that. We don't see, and we have our complaints. Oh, my scan's not getting done. When am I going to get it? And I think we don't always understand that that's not within the remit of the net clinic to do those scans. It's the radiology department, and the net clinic puts in a request, and then they have to wait. And I think, also I do appreciate all the work that's going on to make the PRT available to all of us as net patients, regardless of the clinical indication. And, hopefully you'll be successful in that. And then the last thing, I really like the idea of Tommy as the godfather, because he definitely was. He was pulling the strings all the time of everything, and we really miss him. So with that, I'm going to ask Hussein Almeamar, the first net specialist in Europe, to talk to us about what's happening in Ireland or how the net system works.
Good morning. So I think Dermot, presented a very good overview. Cover most of the thing. So I'm just going to show you a few slides. Some of my disclosures. So just to show you a bit about how the national net service in Ireland evolved over the years. As Dermot said, so started all with a small clinic. It was few net patient was seen in the endocrine clinic with Professor Donal. He's here, and then obviously with Tommy Gorman and Mark, and it was very important to recruit Dermot, international expert in neuroendocrine tumor, to set up the national services as accredited national service in Ireland. And then there was the net patient network was then born. That was all around 2013, 2014. Then another important milestone along the journey is the accreditation as an ENETS, European Neuroendocrine Tumor Society Center of Excellence. That was in 2016. And this is, of course, very important for us and very important for you as a patient. So you know that we follow standards, and part of the accreditation, we have to submit numbers every year, and we need to be audited to make sure we are doing things in the right way. So it's very important milestone. 2019 then, another important milestones is to have finally the gallium PET scan available to patients. And as Dermot said, there is a bit of limitation and access, but this is again a very important milestone. 2021, then we got another accreditation, which is the European Reference Network for rare cancers, and this is again important. So standards, number, so it's important for us and for you as a patient. Again, the center is accredited. 2023, then we got re-accredited after an audit. So it's 5 years, and we got the audit. They came, they saw the center and make sure everything is okay, and they were happy. So this was another important milestone. Then finally, 23, 24, as Dermot said, we got the funding, we got the approval to set up. We started the setup of the PRRT center in St. Vincent. What's next? I suppose now we have evolved over the years from a small clinic, small number of patients, to well-established, fully accredited service. So next is clinical trials, and Professor Mark Doherty will give you a bit of a talk about therapies, and also collaboration in terms of research with other European centers. So this is the ENETS database as a register in Europe, and we ask you when you come to the clinic to sign consent if you are happy to be included. And what does that mean to you as a patient? It means you'll be part of the future in terms of study to improve the management of a neuroendocrine tumor. And with the clinical trial, if we get set up, and Mark will give you a bit of, will give you a talk. We have some good news. That means you'll have access to new therapies. So it's very important. And also, we are the hospital going through another accreditation with the Hospital Cancer Group for a another European OECI accreditation. I'll show you some pictures, how the service evolved over the years. So this was July 2013, when the National Neuroendocrine Service was accredited as a service in Ireland. See Dermot, Donal, Justin Gagan, and Mark. Mark was there from the very beginning, all over these years, involved in this. And then this picture, it was around 10 years later, so we got re-accredited, and Dermot mentioned about Lisa Collin. She was there, and we got the re-accreditation. It was very important. And you see new faces. You see my face. You see Mark. So the service evolved. We have new people joined the service. This is another milestone where we officially launched the PRRT service in Ireland, as Dermot said. So again, we see new people joining the service. So Dr. Nicola Hughes and Dr. Mathilde Columpy's nuclear medicine team to deliver PRRT therapies. And what you can see, this is actually the room where we deliver the PRRT treatment. And you see the late Tommy Gorman was there, and Mark was there as well. And it was an important milestone. The most important thing about management of a neuroendocrine tumor is a multidisciplinary service, okay? This is the key. And there are so many specialties involved. Some of them involve, less frequently, and some of them you see them more frequently. And this is the key, and this to deliver a neuroendocrine service and a center of excellence. And we had a good meeting yesterday with the Irish Cancer Society nurses, and there are a couple of things maybe we need to involve. We need to get them involved and more, and things like psychology aspect, at least, for example, we need to mention that maybe a little more, etc. So there are a few more things we need to improve, but the key here, there are so many people involved in this service, and to deliver the services. A bit of a summary about the pathway. This is a simplistic way to present the pathways. It's way more complex, our SOP. So once you have a NET diagnosis, and this could be a confirmed NET diagnosis, or could be a suspected NET diagnosis, then you start the referral process to the NET center. And this ideally will come from a consultant where you attended, but sometimes could come from a GP. And this, as Dermot said, improved over the years. So the center became very well established, more well known. So most of the consultants in Ireland know about the NET center, and they do send the referral, and we have improvement in that. But sometimes patients would like a second opinion. So the consultant, for example, didn't send them to the National NET Center. And in this case, they approach, and we do accept, for example, if the GP sends a referral letter with whatever information they have, if the patient would like a second opinion. This is welcome, very well welcome in our center, okay? So once you come to the NET service, and again, it's way more complex, it's a simplistic way. We have so many people involved. We have coordinators, etc. We have data manager to manage the MDT. The MDT is very complex. Then the outcome could be, we are happy. So you don't need to be linked regularly with the NET center. There are a few tumors where we say, that's it, fully treated. You don't need even a follow-up. Or sometime, for example, you had the surgery, you had the tumor removed, but there is risk of its coming back. So you would want to have regular scans. And sometime, if everyone happy, the patient and the consultant looking after you locally, we could arrange for these scans to happen locally while they'll be in touch with us. Or you'll be linked linked regularly with the center for a regular follow-up, long-term follow-up and management. This is just a simplistic way of about the pathway. We do have 2 satellite clinics in Galway, Dr. Greg Leonard and Marcia Bell, you saw them last year, and in Cork with Professor Derek Power and Mr. Christopher Sullivan. So it's very important to, a lot of you attend this clinic, and it's important to coordinate with them and to use the clinics as well. So we deliver a better service for everyone. And also, of course, we accept referral from elsewhere in Ireland. We're becoming more independent now because we have the gallium PET, we have the PRRT treatment, but we still sometimes might rarely now need to send you abroad. For example, there are few types of PET scan that's very rarely needed, but not available in Ireland, not even available in the UK. Sometimes send you to other center, etc. But we are becoming more independent. Our MDT, the multidisciplinary team, as I mentioned, is every first, third, or fifth Friday, and the net clinic is every Friday. And we do face-to-face clinic and virtual clinic. If you are a bit far away, difficult to come to Dublin, so we do have this virtual opportunity. Let's just show you a little bit about our numbers. From 2018, obviously, as I mentioned earlier, center became established and accredited before that. So the numbers started to grow. This is our MDT discussion numbers. You see it's become a bit flat around COVID time, but it's going up. It's going up. The new number, this is in orange, and the overall MDT discussion is almost doubled from 2018 to 2024. This is our last year data. So we discussed last year 1,100 cases at our MDT. We are a big center now. And yesterday when we had the meeting with the nurses, there was Kathy, one of the first nurses in the UK, worked in the Royal Free. And she was impressed with the numbers we have here in Ireland as a center of excellence. So what that means for us and for you is mean more new people joining as the service evolved, and mean we are in a good position now to ask to be included in clinical trials, so you'll have more access to treatment. But it also means challenges to the service, because the service become overwhelmed and we need to manage resources and be smart how we manage resources. And as Dermot said, we are, it's the good news, we have a full-time nurse now appointed and AMP to start very soon, and we are looking to set up another clinic to support the Friday clinic, etc. So, and we are waiting for a new appointment of consultants. So this is important. Communication is the most important thing. And I always mention that to patient, and I think I mentioned it to Mark McDonnell as well, to put this in social media. The email that we use, or we prefer a patient to contact us by is the Nest Center email. And we have the nurses now, so Orla, looking after this email Monday to Friday. Obviously before that Lisa was part-time. Initially with the small numbers it was manageable. Over the years become overwhelmed. So we know there was issues with communication, but it's started to get better now with Orla, and will get more better when Anya start to join. So some of you already maybe started to notice the difference contacting Orla in the last few weeks when she joined. So we hope this will make a huge improvement to the communication. The number here is our secretary, Jerry Daly. Sometimes if you can't reach her, it's a direct number. You can't leave a voice message. But I think what Orla and Anya will work on is set up a new phone number where you could access the nurses directly. And we'll put that, we'll update the website. The PRRT service is because it's a separate team, as Dermot said, it's a nuclear medicine team. I work very closely with them because I look at the medical side of it. So if you have issues with for example, you have pain while you are getting your therapies, or any other issues in between your treatment cycles, usually there are 4 cycles. So the nurses, the PRRT nurses are separated for that reason. So the contact then use the PRRT email. Only if you're an active patient going through the PRRT cycles, okay? Although I could be the same, looking after you in the net clinic or while we are getting the PRT, but it's important to know where to contact, or whom you should communicate, or which email you should send if whether you are an active PRT person. Once you finish PRT, we still look after you, but then you need to contact the NES center, please. And finally, this is another milestone in the service. So that was in April this year, almost a year after we officially launched the PRRT service. We celebrated the delivery of number 100 PRRT treatment in Ireland. In just a year, 100 treatment, and we managed to treat difficult patients just because we have a multidisciplinary team and a lot of people involved in this. Some of you who already had the PRRT treatment, you see my colleague in the nuclear medicine department is Nicola, Mathilde there, and also the medical physicist like Anne and Jackie, who's looking after you, and the PRRT nurses. Hillary couldn't make it today. So that's it, and thank you for your listening.
Thank you, Hussein. I know many of us have dealt with Hussein. He's fantastic to deal with and really a great person. But I want to say that, we know that communications is really, it's the biggest gripe we as patients have. And I want to thank Orla for, she was there yesterday and she's here today. And Anya, who's come today, it's fantastic. And Anya hasn't started yet and she's joined us today. So that email, netcenter@svuh.ie, is there, and both Hussein and Orla have said this is not just for St. Vincent's patients; it's for all patients across the country. So if you're not in St. Vincent's, still use the email, contact them, and I think Orla will get much more faster as time moves on in terms of replying. So it's great that's been looked at and improving. So I now want to ask Mark Doherty to give us a talk about advanced treatments in NETs.
Morning, everybody. Excuse me, I'm just going to set a timer on my phone so I don't blather on for 45 minutes. Mark is just going to get the slide set up for me here. Mark asked me to talk about sort of treatments for advanced neuroendocrine tumors. So I'm a medical oncologist. I treat people with systemic therapies, chemotherapies, targeted therapies, immunotherapies, those sorts of treatments for advanced cancers and for neuroendocrine tumors. I always find it a little difficult when speaking in these kind of groups because there's a sort of a wide variety in terms of the people that in the audience, right? There's some of you, it may be, you may have very recently been diagnosed with neuroendocrine tumor or with neuroendocrine carcinoma, or a family member may be in that situation, and all of this may be very new and uncertain for you. And then I know there's others who have been coming to these meetings for more than a decade, who've heard many of us speak at these over the years, and for whom may have even personal experience and may know these treatments even more intimately than I do. So if some of this seems too basic, please give me a bit of leeway there, or if some of it seems too advanced, I'm happy to take any questions or to talk it through with you in more detail. So what I want to discuss over the next few minutes is just the different types of systemic treatment for advanced neuroendocrine tumors, to talk a little bit about the decision-making process, or how I or we as the multidisciplinary team would choose to recommend one treatment over the others. And also then at the end, spend a few minutes just highlighting a couple of new and emerging treatments that have come through in terms of recent clinical trial results, as well as mention an upcoming clinical trial in St. Vincent's Hospital. So I suppose just to start off with, it's important to frame this in a way of what's the point of this? What are we trying to achieve? And I suppose, I always think about this in three ways. So first of all, it's controlling the symptoms of the neuroendocrine tumor. So be that symptoms related to where the tumor is sitting, or symptoms related to the hormonal syndrome that might be associated with the neuroendocrine tumor, and how can our treatments do a good job to control those things. Also then, in terms of the treatment, when we're not thinking about an early stage neuroendocrine tumor that we can cure with an operation, how can we delay or prevent tumor progression? So preventing the tumors from getting worse, from new things appearing, in order to maintain somebody's health, maintain their level of function, and ultimately prolong their life expectancy. And also within that, how do we improve through control of symptoms and maintain through delay of progression of the disease somebody's quality of life? And those are the three aspects of the treatment that the treatment should at least manage to help with 2 out of those 3. And if it's falling down on 1 or more of those, then it's worth revisiting, is this really the right thing to be doing? So there are a number of treatments, and I'm going to go through some of these. I'm going to limit what I talk about to the sort of systemic treatments. So I'm not going to cover surgery or local treatments in terms of embolization or ablation, but I'll talk about those medical treatments because it's more in my wheelhouse, and also otherwise I'd be here for the day. So broadly speaking, what they are, we think about somatostatin analog therapies. We think about what we call targeted therapies, which are in the main oral treatments, pills that people can take at home. And those can be mTOR inhibitors or tyrosine kinase inhibitors. We think about PRRT treatment, and Hussein has already touched on that. And we think about chemotherapy. So I'm going to go through each of those treatments in just general terms and just mention about what they look like and how they're used, or how we think about using them. So many of you here may be familiar with somatostatin analog injections. So these are one of the first treatments that we think about for patients with well-differentiated neuroendocrine tumors. These are injections that are given usually once a month. They could be given short-acting ones, but mostly now people are on long-acting ones, which are a monthly injection. And they're generally well tolerated. So these usually don't have very, very severe side effects, although some people can struggle with diarrhea, with abnormal bowel movements, or other GI upset, cramping, flatulence, that kind of thing. They were first licensed and first brought into development to help control the carcinoid syndrome. But actually now we have evidence from multiple trials over the years that even people without carcinoid syndrome, these injections can help to delay or prevent the progression of the disease. And so with a treatment that we have that can control the neuroendocrine tumor, often for many years, particularly for low-grade, well-differentiated neuroendocrine tumors, we often think about these somatostatin analog injections as the first line of treatment. Because, as I mentioned, and as I often say to people, one of our goals with the treatment of neuroendocrine tumors is to try to minimize the disease as the part of somebody's life. So if all it means is you need a jab once a month, and that can carry on and control the disease, we monitor it with scans, but that can control the disease sometimes for many years, then that's a pretty good outcome and a pretty good way to manage a condition over time. So as I said, we often consider this the first line treatment for small intestinal neuroendocrine tumors, or for those low-grade pancreatic neuroendocrine tumors. PRRT treatment, Hussein has already talked to you a little bit about from a practical and from a systematic perspective what it is, how it's delivered, but essentially just to give you the sort of the chemistry of it, it uses those same somatostatin receptors that the somatostatin analogs bind to on the neuroendocrine tumor cells, but it's attached to a radioactive isotope. And so that radioactive isotope can help to irradiate the neuroendocrine tumors, can help to kill off some of the neuroendocrine tumor cells, and help to control the disease over time. As both Hussein and Dermot mentioned, this is now licensed and funded, and a service has been set up for this treatment in Ireland for grade 1, grade 2 GI and pancreatic neuroendocrine tumors. From a practical sense, you saw pictures of the room where it's given, but what it is it's an intravenous infusion. So somebody gets an infusion of this radioactive isotope therapy approximately once every 8 weeks. That's a little bit of a movable feast based on what the blood test results look like and everything, but the protocol is suggested that it's given once every 8 weeks. It does have probably more side effects than those injections in terms of it can cause sort of nausea and vomiting at the time, but we give anti-nausea medication so people can get tiredness with it. It could certainly have either short or long-term effects on the blood tests, the bone marrow blood tests, so we have to watch that over time. Just to mention, we only do this in Ireland at St. Vincent's Hospital at the moment because of the complexity in the administration. You've seen the kind of team that has to be developed in order to provide this sort of service. So although it may become available in other places around the country in the future, currently at the moment, particularly for neuroendocrine tumours, it's only available in St. Vincent's Hospital. And we have a service, obviously, and a team that accepts national referrals for that treatment here. So moving on then, other treatments. So we think about, I mentioned those oral targeted therapies. So these are pills, and the one that's probably most often prescribed and has been available probably for the longest is a drug called everolimus. And this is what we call an mTOR inhibitor. So I mean, the technicalities of it are not that relevant, but it's a growth pathway that's involved in the survival and proliferation of many types of cancer cells, including neuroendocrine cancer cells. It has clinical trials showing that it can help to control the disease both in pancreatic neuroendocrine tumors and in small bowel neuroendocrine tumors, and also in neuroendocrine tumors starting in the lung after the disease has become resistant to the somatostatin analog injections. It's an oral medication. It's taken once a day at home, but it does require more frequent monitoring than somebody might be on with, for example, the somatostatin analog injections, because it does have more side effects. So people can get things like skin rash, mouth ulcers. It can cause changes in the blood sugars or the blood cholesterol levels. And a small proportion of people who take this can get problems like pneumonia with it. So it is a little bit more, in terms of the side effects, a little bit heavier, but for some people it can work very well and can help to keep their disease well under control, at least for some good period of time. The tyrosine kinase inhibitors are other what we call oral targeted therapies. And those are, again, pills that people would take usually once a day. There are now several of these drugs that are available. Most of them have been studied first in pancreatic neuroendocrine tumors, but we have some evidence now, particularly for cabozantinib, that it can be useful in people with small bowel neuroendocrine tumors. I'll come back to that in a minute. Although these pills can be different, they often have similar kinds of side effects because of the mechanism of how they work. So they cause things like high blood pressure. They can cause, again, a skin rash, some diarrhea. And again, because of those things, they have to be monitored a little bit more closely. So we use these, like I have quite a number of people with neuroendocrine tumors who take these kinds of medications. And I'll come back to how we make those decisions in a second. Chemotherapy is the sort of the bread and butter treatment that medical oncologists are trained on delivering. And in well-differentiated neuroendocrine tumors, the most common chemotherapy that we would prescribe is oral chemotherapy, so a combination of two chemo drugs called capecitabine and temozolomide. And that has been well studied in pancreatic neuroendocrine tumors. It's sometimes we think about that as the first treatment that somebody might have if they present with an advanced pancreatic neuroendocrine tumor, particularly if it looks aggressive, either in terms of the biology under the microscope or the extent of the disease on a scan. Sometimes we use it in a second-line setting if they've had a somatostatin analog injection and that's no longer working. It's fair to say it has limited use in small bowel neuroendocrine tumors, and it's less well studied there. And then there is also, so that's the oral chemotherapy. There is intravenous chemotherapy, and sometimes for people with pancreatic neuroendocrine tumors, we will use intravenous chemotherapy, particularly if they've had the oral chemotherapy before, or for those with what we call poorly differentiated carcinoma, so those kind of much more aggressive tumors, we think about intravenous chemotherapy as the first or the best treatment. And I'm not going to go into detail about that intravenous chemotherapy because there's a number of different chemotherapy regimens, and again, we'd be here for too long. So those are that's an outline of broadly the types of treatment that we think about using for in terms of the medical prescription for neuroendocrine tumors. But how do we decide between one or the other? And really, it comes down to a number of factors. So, what does it look like under the microscope when when they take a biopsy and they look at it under the microscope? How quiet or how aggressive does that tumor look? And that's what we call grading. We use things like Ki-67. What's the burden? How much is there on a scan? Is there, one little area? Are there multiple areas? Does it look like we need to step in with a more aggressive treatment to try and get ahead of this? Or is it something that we can kind of try it more gently approach? What kind of other medical problems does the person have? Are they young and fit with no other significant medical history, or have they got sort of chronic problems with the heart or the liver or the kidneys that might feed into how easy or difficult they might find any given treatment? We look at things like what are the somatostatin receptors? Are they present or not? And that can help to guide us in terms of those treatments that are directed against somatostatin receptors. What previous treatments have they had? Is there a sort of a functional syndrome, what we call like a carcinoid syndrome, or some hormonal excretion that we need to try and get on top of? The other things in terms of circulating biomarkers and tumor biomarkers, so these are things that we like to try to figure out. Is there something that we can do or test ahead of time that will tell us with greater certainty that a treatment is more likely to work for an individual? Because all of these treatments are sort of based on averages for a population, and we're left sort of trying to choose what's the best fit for a person, and the closer we can get to that best fit, the better. So there's lots of work going on in terms of trying to develop new biomarkers beyond what we already use. And this is just that decision-making process represented in a sort of an algorithm where we look at what is it, where did it come from, how aggressive does it look, where is it now, what are the other factors in patient's medical condition, and then what are those options that we might use to select a treatment. The other thing is obviously how well do these things work? So I put this up here just this is an overall study from a few years ago looking at different modalities of treatment in terms of targeted therapies, chemotherapies, PRRT therapies. And it just gives an idea when we're thinking about if we're using those treatments in the right situation, how long are they likely to keep things under control before we have to come up with a new treatment option? And again, sometimes that's relevant, sometimes it's not, but it's interesting to know that there are those differences across the studies. Okay, for the last couple of minutes, I just want to talk about some new and emerging treatments. So I mentioned that targeted therapies, the oral targeted therapy, and the one that's kind of really come on the scene in the last year or so is cabozantinib. So this was there was a clinical trial published at the end of last year in the New England Journal of Medicine, very prestigious medical journal, where it was a trial of 200 people with advanced neuroendocrine tumors. It was 300 people, 200 with extrapancreatic and 100 with pancreatic neuroendocrine tumors. And this was what's called a randomized control trial. So half the people got the active drug, half of the people got a placebo, a sugar pill, and neither the doctors nor the patients knew until they saw some change on a scan. If they saw the tumor was growing or spreading on a scan, they could take the label off the bottle, and if the patients were receiving the placebo, they could move over and get the active drug. And what they found was in terms of controlling the neuroendocrine tumor, for both patients with pancreatic neuroendocrine tumors or those that arose in the small bowel or the lung, the cabozantinib did a much better job than the placebo, and actually a good job even when we compare it to other treatments in terms of controlling their neuroendocrine tumor. It came at the cost of some side effects, the things that I've talked about in terms of blood pressure and skin rash and diarrhea. Those are generally manageable. Some people needed dose reduction on the drug. Some people needed to take breaks here and there from it, but actually it was generally pretty well tolerated. And so that's come into now our armamentarium, and I've started quite a few people on this treatment over the past year. So some of you may be here that are taking this drug at the moment. This is the clinical trial that's on that basis. I suppose at these meetings we tend to focus on the well-differentiated neuroendocrine tumors, but just to, in terms of the poorly differentiated neuroendocrine carcinomas, which are those more aggressive tumors where we have been sort of more limited in terms of new drug development, new treatments that have been coming on the scene. The chemotherapies that we use for that have been around for quite a while now. There is some good development in terms of a new targeted therapy using this target called DLL3. And this was a trial that was presented at the American Society of Clinical Oncology meeting this summer, looking at a new, it's kind of like a type of immunotherapy where it's an antibody that binds to this target on the neuroendocrine carcinoma cells called DLL3, and it also helps to activate the immune system to attack those neuroendocrine carcinoma cells. And this is pretty complicated stuff to go through, but suffice it to say that for people, even people whose disease had proved resistant to chemotherapy, for those that had high DLL3 levels, up to 40% of them had a shrinkage in their tumor when they received this new immunotherapy type drug. Finally, I just wanted to highlight this trial, which will be opening in Vincent's sometime early in the new year. It's called the Care Finder study, and it's a trial of a new oral somatostatin analog therapy. So this has been developed by Crinetics, the drug company, and we're taking part in this phase 3 randomized trial, which again involves a placebo. And so this will be open for people with carcinoid syndromes, those who have things like flushing and diarrhea, and they have to fill out a diary to show the level of symptoms they have going into the study. It'll be open for new patients with newly diagnosed neuroendocrine tumors who haven't received any somatostatin analog therapy before, and also for those who have known carcinoid syndrome where it's under control on their existing injected somatostatin analog therapy. If they are willing, they can participate in this trial. It's a little bit of a catch in that they have to stop that injection and let all the existing treatment wash out. And we have to demonstrate that those carcinoid symptoms return after the injections stop, in that the flushing and the diarrhea comes back. But then they can be enrolled onto the clinical trial. It's a 2-to-1 randomization. So out of every 3 people that go on the trial, 2 get the active drug, 1 gets the placebo for the first 16 weeks. After that, everybody gets the active drug for 2 years. And the hope is that this will become an oral treatment option for patients with neuroendocrine tumors instead of the monthly injections, so ditching the needle. So hopefully that will be a good study. I will be approaching those of you that I've spoken to some of you already about this, and once we have it open, I may communicate through, I say to Justin here, through the Net Patient Network that we have the trial open, and ask you to self-present as well if you're interested in taking part in the trial. I'm happy to talk about it in more detail. Okay, I'm going to wrap up here. So the sort of overall message, we have lots of different treatments for advanced neuroendocrine tumors. And over an individual patient's journey, they're likely to at least have a discussion about most of these treatment options. What we do and what we prescribe and how we evaluate the treatments is always that balance of benefit versus harm or risk in terms of the side effects. And also just to say that hopefully new advances in targeted therapy and immunotherapy will improve how well these treatments work for people. Thank you. Thank you.
Thanks very much. Lovely.
So thanks, Mark. I think that was a great overview of the treatments, and I think it's wonderful to hear that clinical trials are going to start recruiting in St. Vincent's, and I think that's also, as Hussein was saying, the numbers there. So hopefully we look forward to many more opportunities on that. Mark is on call in St. Vincent's Hospital today, so he won't be able to stay for the question and answer session. But thank you very much for that. So with that, I want to ask Donal to give us a talk about MDT care.
Yeah, I think thank you very much. I think MDT care has been very nicely outlined by Hussein, so I might just make a few comments about what we've heard so far and maybe introduce the next speaker. because it kind of is in my space, Alex. So it's really interesting, a lot of the medication drugs that Mark mentioned there were not around when we set up the net service. And there are new, more unpronounceable drugs coming along that Mark was outlining. And the line we use a lot in the NET clinic is that it's about the right treatment at the right time. Because a lot of people think, gosh, PRRT is the silver bullet. Can I have that now? And that's never the right, or not always the right option, because it's possible that you could be stable on somatostatin analogues for 5-10 years before you need the P or RT, and we wait till we see progression. So it's about the right treatment at the right time. Everybody should have an MDT review, multidisciplinary team review, and you've seen the number of people involved in the multidisciplinary team. But even if you're not attending the NET service in Vincent's or Galway or Cork, you should ensure you have the email. You should ensure that your case is put through the MDT. We call it that Friday morning meeting, reviewed, and that you're aware that you're on the right treatment. About Tommy at his book, or his portrait unveiling, I was talking to Ciara and Moya and Joe, and just telling them that when we were accredited for the second time, we brought a copy of Tommy's book to give to the surveyors, and the surveyors were from Uppsala and Germany. And they knew Tommy, and Tommy was a bit of a hero in Uppsala as he was here. And what was the name of his book? Never Better. And we gave them a copy of the book, and they went, never better. But he was well. He did so well. Why would he call his book Never Better? And of course, we were there saying, how do you explain that to a German? That he was... What he meant is he was really well. Why did he say never better? They couldn't get their head around that. And the other story I told Tommy's family was the patient who came back from Uppsala and told us in the clinic that his next appointment was in space. Right? And we said, that's unlikely. Space medicine's progressed, but not that much. And he said, no, they definitely said my next visit is in space. And we went and we got the letter. And of course, read the last line, he will be followed up in your satellite service in Dublin. He heard satellite. And, if you spent 4 days in a lead-lined room 4 times in a country you've never been to, and somebody says space, maybe. And it's interesting to see oral somatostatin analogues. So that's the history of drugs. Injectables become orals and tablets. And shortly, I'm going because Brendan O'Connor wants to cover, after World Diabetes Day, wants to cover the obesity and diabetes drugs. And of course, the big push, they've all been Ozempic and Mounjaro. Injectables, but now the tablets are coming out and are going to be available here, and they're as effective as the injections for obesity, which is great. And we're continuing to make progress in the obesity space. The reason we're making progress in the obesity space is because of the Net Patient Network. Because we were making no progress in the obesity space. We were getting nowhere. And then I looked at what Tommy and Dermot and Mark were doing through good patient advocacy. So in 2016, we set up the ICPO, the Irish Coalition of People Living with Obesity, pretty much along this model. And everything that's happened in the obesity space has happened because of that, which is amazing, really, and it's great. And Justin Gagan, who's sitting down the back there, I think. Stand up, Justin. Thank you for coming. You're very welcome. Justin is retired, as you know, but he is continuing to chair some panels for us in the obesity space as we try and develop national guidelines, and he's liaising with Obesity Canada for us very successfully based on the email I saw last night, which is really good. Yeah, it's a good email. So look, can I introduce Alex, the next speaker? Because multidisciplinary care is important, but looking after yourself is equally important. And that involves good fuel and good physical activity levels, and how do you like to move. And Alex, and there's too many people in this room have been former students of mine at this stage, but Alex is one of them, really good student. Came across him, he's now a GP trainee, came across him at the Sports and Exercise Conference a few weeks ago presenting about injuries during, was it a triathlon or an Ironman? Triathlon. Pattern of injuries during a triathlon. So you need people to be doing research in everything, so you can be ready for whatever is going to come up next. So Alex is going to talk to you about being active.
Yeah, about exercise and cancer.
Exercise in cancer. So thank you very much.
Thanks for that introduction, Professor O'Shea. So my name is Alex Trimble, and I am a doctor with a special interest in exercise as medicine. And I had the privilege of meeting Mark several months ago now when I was working with a wonderful organization called XWell. Out of curiosity, could I get a show of hands of people who've heard of XWell here? Excellent. And a show of hands of people who've actually participated with XWell? Wonderful. Okay, so a few of you have a little bit of an idea of what I'm going to talk about. Before I crack on, Mark's obviously asked me to speak about exercise and cancer. And I'm absolutely thrilled to be here because exercise is something for which I have a ton of passion. Before I get into my talk, I want to do something a little bit silly, a little bit different. So I'm going to invite everyone to stand up, please. Now, the first thing I'm going to ask you to do, I want you to look to the person on either side of you, give them a smile, and give them a wink. Excellent. I find that tends to break the ice nicely. The next thing we're going to do is we're going to have a snack, an exercise snack. Don't worry, it's only going to last for about 10 seconds. So what I'm going to ask you to do, we're going to do just 10 seconds of air boxing like this. Okay, so make sure it might be wise to box up a little bit so you don't hit your specialist in the back of the head. So we're going to go for 10 seconds. We're going to have a big smile as we do it, and we're going to go as fast as we can. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Okay, thank you, everyone. Thanks for cooperating with that. I invite you to take a seat now. So now that hopefully we're all feeling a little bit energized, I'm going to begin my talk. So why is it that I believe so much in exercise? Well, as hopefully you've just experienced, when you exercise, you release these molecules called endorphins, which makes it fun. Moreover, exercise is an incredible means of both preventing and treating diseases, including cancer. Exercise reduces all causes of death. I think that that's such a remarkable comment, I'm going to say it again. Exercise reduces all causes of death. When it comes to cancer, I'm going to speak today just generally about cancers because we don't have a great deal of evidence when it comes to neuroendocrine tumors and exercise. When it comes to cancer, exercise appears to reduce our risk of acquiring cancer in the first place. But for those of us, all of us in the room here who have cancer, there's really exciting accumulating evidence that exercise might actually slow its progression. It may reduce its recurrence, and it improves survival with and beyond cancer. In the last few decades, there has been an absolute avalanche of research looking at exercise and cancer. And I was blown away by some of the research that I read in preparing for this talk. For example, it's been shown that exercise reduces cancer-related fatigue. Exercise improves overall sense of wellness, quality of life in people living with cancer. Exercise appears to ameliorate or improve cancer-related stress and anxiety. It improves body image and, unsurprisingly, sleep in people living with cancer. Exercise appears to improve any individual's ability to tolerate cancer itself, but also its treatments. Not only does it seem to reduce the burden of side effects associated with cancer, also it reduces the burden of side effects associated with treatments like chemotherapy and radiation therapy. But in addition to that, there's really exciting evidence beginning to emerge that it may even improve the effectiveness of those treatments, which I think is absolutely remarkable. I lost my train of thought now. So, stepping away from cancer in isolation, I like to say that if exercise were a drug, I believe it would be the best medicine in the world, and a medicine with virtually no side effects. Increasingly, I think that we're all aware that exercise is good for us. I think the elephant in the room is, how do we actually implement exercise into our busy lives, especially when we're living with cancer? I'm going to make a few general considerations about exercising with cancer now. One, I want you to know that exercise has been shown to be safe and effective when you're undergoing cancer treatments. Unfortunately, it does appear that your fitness is going to suffer when you're undergoing treatment and when you have advanced cancer. Therefore, the goal has to be to begin your fitness having built up as best, or to begin your cancer journey, to begin your treatments having built up the best fitness levels that you possibly can. And when you're undergoing treatment, the goal is to maintain your fitness levels. If you know that your immune system is going to be compromised, it's probably a good idea to favor low intensity exercise. And how do you know if your exercise is low intensity? Well, if you can talk or hold a conversation when you're doing it, it's low intensity. And we call that the talk test. Another consideration when your immune system is compromised, if you choose to do group classes, which I highly recommend, that might be a good time to do the classes online. But should you choose to do it in person, I would highly recommend that you engage in social distancing and you engage in very pedantic hand hygiene to reduce your risk of getting an infection. Now, I'm going to talk a little bit about behavioral change in general. So when you're trying to cultivate a new habit, it is really important to have a clear goal. It's important to start small and to build up slowly. It's important to celebrate each and every win along the way. So every time you enact that habit, It's really important that you celebrate and you reward yourself. Finally, it's critically important, and this plays out in the evidence, that there's a social component to the new habit. And that's the case when it comes to exercise. So I think that is exactly where programs such as XWell absolutely come into their own. So for those of you who don't know, XWell is a not-for-profit social enterprise that provides supervised, structured, and community-based exercise programs for people living with long-term illness. It is very low cost, and it provides a wonderful social network that makes exercise easy, safe, and most importantly, fun. And you can be referred by any healthcare provider who has access to your full medical records. Now, if that doesn't float your boat, when I was preparing for this talk, I came across a wonderful website called cancerrehabilitation.ie, and I'd encourage you to take a moment to even make note of that. It's called cancerrehabilitation.ie. And on that website, there's actually a map where you can search by location and you can find services that provide exercise for people living with cancer. So I'm going to finish this brief talk with a challenge for you. Wherever you might be on your exercise journey, I want you to ask yourself, how can I start to implement this exercise medicine? And I would encourage you to not try to figure that out on your own. I'd encourage you to talk to your doctor. Consider engaging with a program like XWell. And you're very welcome to reach out to me as well if I can be of any assistance. You can get my contact details through Mark. So thank you very much for listening to me, and I wish you all the best.
Thanks very much, Mark. Thank you. So thanks very much, Alex, for that, and thanks, Donal, for your talk on MDT. So yes, for anybody, I actually did the XWell program, and I thought it was fantastic. And Alex talked on my induction, and I thought it was a very inspirational talk. So, you know, it is about integrating exercise into your daily routines, really, and knowing what to do and how to cope with it when you're living with a long-term illness. So thanks very much for that. Donal, I know Donal will have to go shortly. He's on the radio, but thank you very much for that. And I think that just one of the things about MDT is that, you know, everybody with neuroendocrine tumor or neuroendocrine carcinoma, you know, the treatment needs to go, or your plan needs to go through MDT. And any of you that's not in Vincent's, you know, make sure that your case is being seen by MDT or being referred to the national MDT through Vincent's. So now, yeah.
Just one more thing. This time last year, I asked everyone to have a look at my TED Talk. Some of you will remember that, and many did. Thank you very much, and commented. That could be a TED Talk. That should do a TED Talk on that. Why not? But yeah, no, thank you very much for that. I meant to say that.
So I'm going to ask Catherine Donohoe of the HSC Treatment Abroad to come and to talk to us about the role it currently has to play given the changes that have happened in the net system.
So good morning, everybody, and I suppose I'm quite happy to still be invited along, given that your reliance on access to treatment abroad has now almost dissipated with the provision of the service of PRRT in St. Vincent's. Mark is just putting up my slideshow there, but just by way of introduction. So I manage what's called the commercial unit in the treatment abroad in the HSE. So I have responsibility for the treatment abroad scheme, cross-border directive scheme, Northern Ireland Planned Healthcare scheme, cannabis reimbursement scheme, living donor reimbursement scheme, air ambulances, National Virus Reference Lab, all those things fall under my remit. So if you think that we're ignoring you at any stage, please just understand we sometimes have competing demands. So that just gives you an overview of some of the things that we look after. The overseas department, by the way, is the department. So if you've lived and worked in Ireland all your life and you're in the happy position to retire to Spain, well, the overseas department is the department that you apply to so that your healthcare is paid for in Spain by the HSE. It's just another scheme that people aren't really aware of. So EU regulations. So the treatment abroad scheme is based on EU regulation. It gives patients legal rights. Everything that any public servant does has to be based in legislation. If you work outside the legislation, you're not necessarily working illegally, but you are working what they call ultra vires outside legislation, and you should not be doing that. So our remit is covered by EU regulations. The treatment abroad scheme is specifically based on prior notification, prior authorization. You must apply to us specifying exactly what you're looking for the funding for before you go. If you go and then ask us to approve the funding, the answer will be no. It's legally required that you have approval before you go. Here are some of the other things that are of relevance about the treatment abroad scheme. It is a highly specialised scheme. It is only for treatments that are not available in Ireland, or for treatments which there is a delay in accessing in Ireland. And the bar to meet the undue delay criteria is very high. The European Court of Justice has said it is the extent to which your condition will deteriorate beyond a point which can be achieved by an earlier intervention. Very technical, very hard for any doctor to prove, but those are the main criteria of it. It must be a proven form of treatment, so you cannot access clinical trials on the treatment abroad scheme. We've covered the not available in Ireland. You must be referred by a consultant. You can't self-refer, and you can't use a GP referral. And the consultant you're attending must be a public consultant in Ireland. If you're going to a private consultant, go to Leah, go to VHI, go to Irish Life, whoever your private health insurance provider is, and apply to them. They fund treatments abroad in the same way we do. The patient is legally entitled to the treatment in Ireland. So is it a treatment that you would have been legally entitled to in Ireland if it was available? Cancer treatments easily fall into that criteria, so that's not something you will ever have to worry about. Historically, NETS patients have been travelling to Uppsala, Rotterdam and London for PRRT treatment. Dermot spoke earlier about the limits of PRRT treatments available in Ireland. So what that is that because PRRT is a drug therapy, drug therapies are only licensed for certain conditions in Ireland. So if your condition is outside that for which the PRRT is licensed, then you can't use the treatment abroad scheme to get it. And we've had a number of cases declined by our service, by our funding in the last year, and that has been heartbreaking, firstly for the patients, secondly for the consultant, but also for our staff. The impact it has on staff who see patients applying for a treatment they know is available, they know we funded previously, but these particular patients are falling outside the criteria. That is heartbreaking for everybody. We continue to allow patients who would be eligible for the treatment in St. Vincent's Hospital to access it abroad. And the reasons where you can do that are, one, there's a delay or there's a lack of capacity in St. Vincent's, or two, where the consultants might say, well, yeah, look, this patient is either so complex or they're so far into their treatment plan that they'd be better off continuing to access the treatment in Uppsala or wherever it is. But that is very much on consultant recommendation. So here are the criteria for the treatment abroad scheme. A public patient in Ireland. The treatment is identified as a proven form of treatment. It is not contrary to Irish legislation. the patient would have been entitled to the treatment in Ireland. The treatment is not available in Ireland or not available within time clinically necessary. And that's it. I'm not going to, you're all so familiar with the treatment abroad scheme that I just don't feel there's a need to labour this, and it might help Mark with his timing for the questions and answers. So thanks a million.
Thanks, Catherine. Thank you. So Catherine has been a friend and supporter of us throughout all the years. 14 years now you've been coming, Catherine, so really appreciate that. So we're slightly over time. We have a break to come, but just before the break, we're going to ask Mary O'Brien, one of our committee members, to give us a quick overview of our social media channels and communication channels. So, Mary.
Good morning, everyone. My husband and I would like you to thank you for attending today's Net Patient Day. We both run the 2 voluntary Facebook groups called Neuroendocrine Cancer Ireland Support. These groups are patient helping patients. Our main Facebook support group is for everyone, patient carers and their families. Our second group is a patients only group, and only patients are allowed to join this group. This way patients can discuss patients' issues privately. There's also a thing that you can talk about your partner that, oh, they're annoying me and all this, because your partner could be in the group and you're trying to cope with everything. So I always say this is a joke that patients can give out about their carer or their family member that's not understanding, and other patients who understand this, and your husband or whatever can't see it in the main group. Both groups have increased in numbers again this past year. We have a total of 567 members. We are thrilled to see both groups are successful and that patients and family members are answering posts, commenting and offering support, help, advice and friendship. This is what happens in our groups. They should be called support each other groups. We are aware many patients here are not in the Facebook groups, and we would love if you could all join. There is no requirement to participate in the group, but you all know that there is an option there if you need to. Join in the groups. If you're interested in joining, go to Net Patient Network website and look at the top menu, look for patient supports, click on Facebook support groups, follow the instructions from there. We would like to thank all the members of our Facebook groups for making them so successful. We have so many members who welcome new members, answer questions, or give their opinion in a conversation, and we really appreciate this. We have a file section. A reminder to our members that we have a file section in the group that all members should visit. There is a lot of net-related information specifically for Irish patients, especially for newly diagnosed and anyone heading to Sweden for treatment. We are looking for volunteers as well who have done the PRTT treatment. If they could write a brief description of it that we could put up on the file, so that would help other people. And if anybody has any information that they would like to share, they can send it to the webpage and we can put it up in the group as well. Newsletter. There is a Net Patient Network have an email newsletter. You can sign up for it on the website. At the top, look for patient supports. You will see the link. When you get to the page, you will fill out the short form and then click subscribe. Facebook page. We have a Facebook page. This Facebook page is for everybody. So when you go onto the Facebook page, you will go to the search box and you can search for Neuroendocrine Cancer Ireland. Just look at the Net Patient logo. We would appreciate if you could ask family members and friends to like the page and ask them to share it. So if you're a GP that's here now, that you could ask all your friends to like the page and share it, because we're still trying to get the word out there. So anybody at all, your business partners, your friends, family members, whatever, We would like to thank everyone who have offered to volunteer to help out at last night's dinner and today's events. All our volunteers are truly appreciated. Everyone working together makes this year successful. Let me begin by like to thank all the doctors and medical staff for everything they do for us patients, especially for taking the time to come for our Net Patient Day. It's great to see them all again this year. Thank you.
So, thank you, Mary, and I think many of us have interacted on that Facebook page, and the great work that Mary and Owen do in keeping that live. Anybody who's willing to help out, I think Mary would really appreciate any support on that. So we're going to break now for tea and coffee, and it is, so it's 11. Let's get back by 11:15. There's 4 tea and coffee stations around, so please help yourselves. Thank you.